Yeah, so we're going to be chatting about how to match the polyp to the endoscopus or the endoscopus to the polyp, whichever way you want to look at it. And basically, it's crucial to optimize outcomes and to prevent adverse events. So we're going to be discussing the components of the SMSA score as well as the SMSA plus score. So why the need to do this? The need is because there is quite a large variation in terms of outcomes as well as adverse events in polypectomy. And this results in unnecessary treatment and over-treatment for lots of patients. It may result in high rates of surgery for benign disease, post-colonoscopy colorectal cancer, for incompletely resected polyps, multiple procedures, unnecessary surgery, or even repeat procedures for incompletely removed polyps. So the first step that I usually take when looking at a polyp and when deciding if the polyp is, within your reach or within your domain in terms of resection, is just to ask a few simple questions. Firstly, is the polyp actually endoscopically resectable? And if it's not, if it's clearly invasive, then that's a candidate for surgery. The second question to ask is the polyp for today? If the answer is yes, the next question to ask is the polyp for me? So do I have the expertise to deal with this polyp? And then finally get into technique. It's amazing. I work with quite a good anesthetist back home, and she's often heard me ask myself these questions. And at one stage, she assisted another gastroenterologist in another center. And a few days later, I got a call from the gastroenterologist telling me that I found this polyp. I wasn't sure if I should deal with it. And your anesthetist asked me, is this polyp for today? Is this polyp for me? And he was actually quite appreciative of that and decided not to deal with the polyp and send it back to me. So I think these are simple questions which one can ask themselves. So what is the SMSA score? The SMSA score simply stands for the size, morphology, site, and access of the polyp. Larger polyps, more flat lesions, polyps on the right side, and polyps with difficult access score higher. Using this score, you can risk stratify polyps according to SMSA levels between 1 and 4. So an SMSA polyp of 1 being the easiest polyp and an SMSA polyp of 4 being the most difficult to resect. And is there literature to support that the score actually has clinical relevance? And there is. This is a study done by Michael Burke's group, which shows that as you go up in the SMSA ranking, your technical success decreases. You have more intraprocedural bleeding. You have more delayed bleeding. You have more delayed perforation. And you also have higher recurrence rates. So this nicely graphically demonstrates the outcome of that study. An SMSA2 polyp with a median procedure time of 10%, a success rate quite high of 98.7%, and low adverse event rates. And this is in contrast to an SMSA3 polyp, longer procedure times, less technical success, and more adverse events. And finally, an SMSA4 polyp with more procedure times and even worse success rates and more adverse events. And these findings have been replicated in other studies as well. And you can see in the top study that the SMSA polyp level correlated with incomplete resection rates and the need for additional procedures. In the bottom left, again, you see rates of residual or recurrent adenoma. And again, you see that there's quite a big divide between SMSA2 polyps and SMSA polyps. So SMSA2 polyps having a 1.9% recurrence rate versus 4 polyps at 30.8%. So this is quite a significant difference between the two. Looking at the Kaplan-Meier curve on the right-hand side, you can see again a wide variation when you classify polyps according to the SMSA score, and this just stratify them according to SMSA2 and SMSA3 and 4 polyps. So this is another study that was recently published in Endoscopy, and it looked at a case selection score, essentially a score used to match, again, polypectomus to the polyp. And again, it showed that this can be predicted using these elements. And this is not quite the SMSA score, but what I really wanted to highlight is that it's essentially the same components. It's the size, nodularity, or a nodular component, and difficult occasions. So again, validating the previous parameters in just a different format. There is then the SMSA plus score.
So to summarize, how do we prevent recurrence? Well, we try to prevent it happening. Right polyp, right endoscopist, SMSA score. As Vikash said, make sure no residual adenoma within the defect or the margin. Do margin ablation to all polyps over 20 millimeters in size in 2023. How do we detect recurrence with a standardized protocol? And how do we treat it? Snare resection or snare tip soft coagulation. And, cold avulsion and snare tip soft coagulation. If you look at this and remember the talk I gave just before lunch about blink features, then this does have a depression here and like a breaking of a fold. But remember that this is not validated in this situation. So this is a scar. It's clearly a scar. Why? Because there's pale mucosa and the vessels, which you can see here at the 7 o'clock, another one at the 10 o'clock, they cannot be followed into that white area. So that's number one. Number two, you have associated with that scar a significant amount of recurrent adenoma, or actually maybe residual adenoma, associated not just with one area of the scar, but all around the scar. And actually, if you look, probably at the top there is also some adenoma. So why do we think this is recurrent adenoma or residual adenoma on a scar? Because when we go to virtual chrome endoscopy, the pattern of the scar, which you can see in the bottom left of the image here, a little bit of light reflection, those open pits are interrupted by branching vascular pattern of at least 1, 2, 3, 4, I think, separate areas. And that really goes to show what I was saying before, right? So I just presented you a study where we found that the majority of recurrence is, and we're talking about that study, by the way, I maybe didn't say it, was in over 20 millimeter lesions, right? This lesion was definitely not 20 millimeters in size, ever, even before it was resected. So that study was in an expert center. But actually what we do know is that if you look outside of expert centers, and I say that I know it by observation, I'm not sure that I know it from a study, that recurrence tends to be growing all over the scar. And we did see that at the initial part of the ACE experience, where we're not very good at polypectomy. You didn't really understand how to do it properly. And you saw these multifocal recurrences over scars. And over time, they disappeared and became single islands of recurrence. And then increasingly, you see no recurrence. So here it is, underwater. What do you think, Yuichi? You want to see MBI?
No, I can't see any evidence of having adenoma in this area.
Okay. Anybody else think there is something there? What about this thing here? Let's go virtual.
Same as the surrounding area, the pit pattern is quite uniform and the vessels are quite narrow and regular form. So it's just a normal course, I would say.
Okay.
I don't think there is visible recurrence, but what about that bridge between those two snare resections you did?
Yeah.
And how do you know there is microscopically maybe something that
So your question is, how do we know there's not microscopic residual between that? I'm just not sure that little nodule there isn't something. Maybe it isn't, maybe it isn't. But it's a good, anyway, if it potentially is, it's a good excuse for me to demonstrate the other technique, forceps please, that you can use to rid yourself of any of this tissue in the middle, right?
So we will now continue to the talk on cold snare polypectomy in 2023. So if you could put up that presentation, thank you. I must say, I'll talk about the lecture objectives. First, it's about polyp selection. It's about technique and the expanding role of cold snare polypectomy, where we have to bear in mind snare choice, technique, defect assessment, and bleeding after cold snare polypectomy. It's, in other words, all about technique and selection of the right lesions. I must say, I thought I'd do an update. I've done this talk many times, will be easy. And then I did 2023, and there are hundreds of articles on cold snare polypectomy. It was a hard one to do, in other words. But it is an update. It's the most recent literature. And apart from this slide, I think you will only find publications done in 2023. So we have to say that the majority of polyps are diminutive or small, and that the risks of cancer in these polyps are very low, with the estimates all at the lower end of this range. When polyps increase in size, 10 to 19 millimeter, their risk will only be slightly greater at 0.9%. So basically below 20 millimeters, cancer risk is relatively small. Why would we do cold snare polypectomy? Because it's safe. We avoid the adverse events associated with diathermy, delayed bleeding, and perforation being the main ones, the ones where we will put our patient into trouble. They'll have to be admitted, maybe have a repeat procedure, in worst case scenario, surgery. So what you can see, this meta-analysis nicely shows the benefit for safety of cold snare polypectomy over hot snare polypectomy. Polyp selection. So we know that cis-ulcerated polyps without dysplasia of any size, we know what they look like. We have to recognize them first before we can decide on the treatment. We have the WASP criteria to help us look for in a perfectly clean colon, look for a little bit of stool because it's often adherent to the polyp. They rarely are fibrotic, have a loose submucosa, so they're perfectly amenable to cold snare polypectomy. Recurrence rates vary. Unfortunately, there is the CARE study, which has been cited so many times, and which is really important, I think, because it reflects a bit real life rather than expert experience. So for serrated polyps, we will see a relatively high recurrence rate even with hot snare polypectomy. So this has all to do with delineating the margin of the cis-ulcerated polyp. Now, cold snare for large cis-ulcerated polyps has been proven in this very recent study in 2020, sorry, it's a bit an older study, but it shows that actually at the first surveillance colonoscopy, the recurrence rates are low. However, again, in expert hands, and we must say that submucosal injection really plays a role here, that recurrences will mainly occur in the where polyps were resected, cis-ulcerated lesions were resected without submucosal injectate, again emphasizing the importance of delineation of the lesion. Again, the safety profile versus endoscopic mucosal resection, the conventional technique, are dramatic. So what about non-pedunculated adenomatous polyps? Lower, below 20 millimeters, but 10 to 19 millimeters. Well, again, to cite the CARE study, 10 to 20 millimeters polyps will have a relative risk of incomplete resection of 2.1. Now, a recent meta-analysis has shown recurrence rates for cold snare EMR in 6.7% in 2,590 polyps. And actually, this ulcerated lesion recurrence rate was lower than the adenomatous rate. The larger polyps are getting, the higher risk, the higher the risk of recurrence will become. And there are some risk factors such as older age, larger polyp size, as I said, and advanced histology that will contribute to the risk of recurrence. So, in general, the studies published the past year are heterogeneous in a way that they include sometimes 4 to 20 millimeter polyps, 10 to 20 millimeter polyps. So we have to bear that in mind a little bit. But we know that incomplete resection rates are as high as 19% amongst non-experts, with, again, showing highest for serrated polyps in contrast to the previous slide. I think this is true. The serrated polyps are the hardest to delineate. And we must say that there is actually failure rates of 63% for 10 to 20 millimeter polyps. And let's say again, this is non-expert center. So this is a real world experience. Others show different. So here, when we do submucosal injection prior to the cold snare, we will have lower incomplete resection rates. So, and then this expert study will show incomplete resection rates that are even lower at 2% for polyps between 10 to 20 millimeter. That was. I think again, we have to bear in mind that we do not mix up expert studies performed by people who don't do anything else but these polyps versus just the day-to-day cancer screening programs. And we have to be aware of that when we read these publications. So submucosal stalks or protrusions, there's a lot been written about that. We used to say they definitely do not need treatment. They're just bunched up submucosa, muscularis mucosa. And, but a recent study may have shown something a little bit different to that, actually. There was made a difference between forced cold snare polypectomy and just conventional cold snare polypectomy. And forced meant that you actually had to apply the guillotine technique, pull your snare against your scope, which is more in larger lesions. The larger it makes sense, right? The larger the lesion gets, the harder it will be to transect. So your relative risk of a protrusion will increase 2.3 fold. When you have to do that technique, protrusions will occur in almost 100% versus 6.4%. And they see it more in sertals-related lesions. I cannot explain that. I don't know why that is. And incomplete resection rates were higher in the group with protrusions based on margins of the pathological specimens. I'm not sure if that has to do actually with cold snare itself or with the fact that a larger lesion, you have to have the appropriate snare, you have to have your rim of normal tissue. Has it really got to do with that stalk, or has it got to do with the size rather than the stalk itself? So they say avoid forced cold snare polypectomy, but bear in mind, these were not biopsies of the protrusion. So does the snare matter? Do we need a dedicated cold snare? Can we use a standard snare? Do we need to open 2 snares in one procedure? They're all very economical and environmental things we have to bear in mind when we make these decisions. Actually, the snares have not really shown to be contributing to complete resection. So it's more about technique than it is about really snare wire. But I think we can all agree that when you have a thinner wire snare, it will just transect more easily, and you'll be able to inspect the defect better because you'll have a cleaner defect and so on. So the technique has been described beautifully here by in the study by Burke, I thought, the Van Hattem study. But basically, David came up with this fried egg image, and I think we can all remember a fried egg. And we want our polyp be the yolk in the middle of ours there and have a nice rim of normal around it. And then I think our complete and incomplete resection rates will be something we can really look at if we have applied the technique right. And I think if we do it right, our incomplete resection rates might be a bit not as high as presented here. So I think technique is a thing to do. If you're not sure, just get a second bite of better that than having to come back 5 years later, which is your normal surveillance maybe that you would have done, and find a recurrence and all the problems that come with that. So aim for the fried egg. Visualize snare closure, close till resistant, confirm placement, cut. If need be, you can do some gentle traction. Never be aggressive. in the worst case, you revise placement, but you do not add HOT. You don't have, because that will be probably lead to some muscularis injury. Then you really have to assess your defect. I think that is also one of the key things that has not been properly done or explained or studied. I think we really need to inject the defect, expand it, so we can really look at all the margins and decide whether we need to do an extra snare bite to make sure that the polyp has been completely removed. If in doubt about the margins, you can inject underneath with a chromic dye, and that will help you to delineate the margins again, especially in serrated lesions, and you can always excise. It's perfectly safe. There's no limit to defect size in contrast to hot snare polypectomy. So for a large SSP, this is I wanted to show you this example. So a lot has already been done. This is a typical cold snare defect where you see a little bit of those more smaller capillary vessels rather than what you see in the deeper submucosal layer, because obviously with cold snare we don't go as deeply into the submucosa, and so you see you cannot really well delineate the borders here. So injection will really help us to see how far we have to go. Look at that. You would never have seen that without injection, and you would have left a whole lot of polyp behind. I think even an expert, because the study of Berg's group also showed that the recurrences happened in the sessile serrated lesions where no injection was used. So look at that, the margins becoming really clear with the chromic dye, and you just do it sequentially. It's actually really fast because of the loose submucosa, the thin mucosal layer, it peels off so nicely, and it's very safe for patients, especially those using anticoagulants. They're the ideal candidate for this. And I think I'll have an image of at the end. So look at that. That is just beautiful. Really done in expert hands again, but this is what the defect should look like. And as you can see, margins are inspected again and again and again, just to make sure we have the entire polyp. So should we inject for small polyps? What's the impact of that? It doesn't really make a difference, only in procedure time. And that's the negative side of it. So for small polyps, we shouldn't really inject. Bleeding, we think only spurting needs treatment, but that, I think I've never seen that in a cold snare, only in hot snare. You should observe if you're in doubt, maybe with patients under anticoagulants with a bad kidney function. They may bleed a bit longer, cirrhotics, I don't know, coagulopathy. Just observe a little bit and use the water jet. There is a study on antiplatelets as well from Australia and New Zealand, and they had a group where they continued clopidogrel and stopped clopidogrel, and actually the intraprocedural bleeding was higher, but not the delayed bleeding. And I think that's an important message, that you apparently don't really have to worry about clinically significant delayed bleeding after cold snare polypectomy. Take home messages. I think cold snare is the safe way to go for polyps under 10. We know that incomplete resection rates increase with polyp size. Use submucosal lift, especially in sessile serrated lesion. Get the technique right and be your own biggest critic, as in here more is less. Don't be happy for don't be happy with a small defect. Go for some extra on the margins, and you will have better outcomes for your patients. Thank you very much.
Sorry, Lob, just to come back to the question in the chat, I did misinterpret it. For a 2A1S lesion, for the purposes of the SMSA score, I would certainly go with a higher score, so score the flat, but a 3 rather than a 2.
Okay, no, definitely. Agreed.
There was another question in the chat about clip removal. Did you do that one already?
No.
So they asked if there's any tips. Maybe we can ask Yuichi. Are there any tips for removing clips?
Oh, that's a good question. I just remove it.
Yeah.
Do it.
And do
There's
it with
almost no risk of making perforation.
I think that I totally agree with that. So a lot of people are worried, aren't they, about perforation or problem?
Yeah, that's why I asked this question.
Yeah. Oh, you asked it.
No, not really. But I expected this kind of follow-up question after my question.
Yeah. I think it's very safe. I totally agree with you. And just what? Use a snare or a biopsy forceps or something? Yeah. I think you can use a rat tooth forceps, crocodile forceps. You could use a snare. Yeah. Lob, are you taking off clips?
Yeah, for sure. But because also, it's not just you need to inspect your scar and your possible recurrence, but you can't really see your clip artifact properly.